Hi there, I'm Lucy Macdonald, physiotherapist. Welcome back to my virtual clinic. Today I'm super excited to be introducing you to Mr. Ahmed Ibrahim from London International Patient Services. He is a neurosurgeon, so specialises in anything to do with your back, spine, neck. And today we're going to be talking about neck pain, what causes it, and most importantly, what you can do about it. So, is there anything else that you would like to add, Ahmed, to introduce yourself a bit further?
Thank you very much, Lucy, and thanks for having me. This is absolutely great opportunity to talk about this. I am a neurosurgeon. I do specialise on most of my practice is actually in the spine.
Excellent, excellent. So let's get cracking then. What would you say, what is the most common causes of neck pain? So if anyone out there who's watching this and has neck pain, what are the most common causes?
I just want to reassure everybody here that the vast majority of people will experience some form of neck pain at some point. But the good news is that the vast majority of that is actually completely benign and self-resolving. So you're really not going to need to even go to the doctor or have treatment for it before you even arrange those things. Most of the neck pain will settle. So when you talk about neck pain, there are three main components. One is the soft tissue area, which is the muscles and the ligaments. The next structure are the bones, and there are 7 separate vertebrae in the neck. And in between those, there are discs. So you've got the soft tissue, which is the muscles and the ligaments, the bones, which you can see that Lucy's pointing to, and then you have the discs in between those bones. Okay. The majority of things that or pain that people will complain of is that of soft tissue, i.e. the muscles, ligaments, etc., as I mentioned earlier. The next problem would be bony problems, for instance, in trauma, if there are any injuries, road traffic accidents, etc. That's quite common. It's a common area that gets injured because it's a highly mobile area. If you think about it, you get hit by a vehicle and everything stops, the neck is jolted forward, etc. So it's a highly mobile segment of the spine. That's why it gets injured quite frequently. And some of these injuries can translate into injury in the disc, which can then herniate out and cause problems with the nerves. Now, there are problems that are serious that you've got to address. For instance, if there is a disc that's pressing onto your spinal cord, that you'd know by having real problems with using your hands and your legs. And you'd know about these. These are not normal functions. So you'd know that the function of your hands are not normal. Okay, in those circumstances, you've just got to go to your doctor and get that looked at. But the vast majority falls in the category where you have pain coming down from your neck into your shoulder and possibly in between your shoulder blades or down your arms. Okay, that's fairly common, and that happens from the age of 30 onwards. And again, the good news here is they actually resolve by themselves with a bit of help. Okay, and that help usually is physical therapy, followed by possibly injections to target the nerve roots to try and get that pain to settle down and allow return of normal function. Mm-hmm. Rarely we have to operate. Okay, go ahead.
Sorry to interrupt. I will ask a bit more about the surgical side of things, but if people are watching this at the moment and if you'd like more information about the sort of physio exercise side of things, which as Ahmed says is most neck pain resolves with that kind of treatment, then I will do a separate videos. There are some separate videos on those topics, but obviously as we have Mr. Ibrahim with us today, I think we'll focus a bit more on the treatments that obviously he specialises in. So sorry, do carry on.
So the pain that fails to respond to simple therapy, those are the patients that tend to be about 30% or so that come to our services. And again, we start off by doing simple things first and go on a stepwise fashion in terms of how invasive we're going to be. So the first thing is it's an option of a nerve root injection, and that quite often is done through CT guidance, that they can target specifically one of the nerve roots. And because there are big blood vessels next to the nerves, it's usually done, it can be done with X-ray, but usually with a CT scan. If that doesn't work, then there are two main standard operations that we do. One is removing the entire disc. It's called anterior cervical discectomy, i.e. removing the damaged disc that's causing pressure on the nerves. That can be replaced with a material that will take its place, which can be made of various different materials that we don't necessarily need to go into now. So that is a very good option. It's an operation that's been around since the 1950s. It's tried and tested, and it works really well. Going on, so sometimes if the pain is very specific in one area of the nerve, we can do an operation through the back of the neck. And these days I do this kind of operation through small keyhole operation, literally go to the area that's causing pressure on the nerves and open up the space for that nerve, allowing restoration of function, reduction of pain. It's a relatively small operation. It can be done as day case, and patients are allowed to move their necks normally without necessarily needing a brace or a collar or any of that materials. It can cause a bit of neck pain afterwards, but that's temporary. It usually lasts 48 hours or so. So that is another good operation. And the keyhole surgery aspect of it is relatively new, and it works extremely well. Disc replacement is the other option, but these are probably 10% of people that undergo surgery are eligible for this treatment. So it's a selected group of patients.
Thank you, thank you. I know you've just simplified something that is incredibly complex, so I really appreciate you doing that for us. I think one of the things that I know that people ask and are very interested in are the risks attached to the kind of procedures that you're describing. So, for example, you mentioned the injection. So I'd just be interested to hear, and I'm sure our viewers would be interested to hear what the risks are associated with the injections elements, and also the different types of surgery that you've mentioned. And not to sort of dwell on it too much, but just to give us a bit of an idea of that.
So the most common risk of injection in the neck is injury of the surrounding structures, and that's why it's done under CT guidance to be very accurate in placing the needle. There are a couple of blood vessels nearby that can potentially get injured. The nerve root itself can potentially get injured, but these risks are very, very small. I've seen one or two so far, and nothing really lasting problems that can arise from that. But if the injection happens to go in the really wrong direction, i.e. spinal cord, obviously that would be major problems. It has been reported. Fortunately, it doesn't happen very often. Risks of the operation from the back of the neck, the keyhole surgery that I mentioned, that's relatively speaking a good operation because the risks are small. It's done under general anesthetics. Obviously, general anesthetic risks go with it. But the actual procedure, the only structure that's at risk, which is directly under the operative field. Injury to that can cause numbness in that particular nerve, or potentially weakness in that particular area, in the same place that the patient usually is complaining of. Now the operation from the front of the neck, now that carries potentially risks of injury to the structures surrounding the area. That's the windpipe, the gala, the nerves for swallowing, and the nerves for vocal cords. So these are at risk. Hoarseness of voice can happen, and this is one of the reasons that singers usually prefer to have an operation through the back of the neck rather than the front of the neck. If you're a professional singer, that's what you'd want to do, but generally speaking, it really doesn't occur very often, fortunately.
And I think that sort of brings me on to something that we haven't really touched on so far. It's around how you choose what treatment. And I know it's an incredibly complex situation. And I think what's so important, and I know this is how you go about making your choices, is that you're really assessing that individual and what that individual needs at so many different levels. But if you could perhaps touch on that, that would be helpful.
So thank you for bringing that up. That's absolutely crucial. So every treatment's got to be tailored for that specific individual patient that's in front of you. And people vary in terms of their demand in their function. There are sports personalities, for instance, that really want to get back to sports as quickly as possible. And there are, even wrestlers, for instance, that have come with neck disc problems that want surgery and want it quickly. There are others that can tolerate a level of pain and say, well, you know what, discomfort is not particularly bad, so I can tolerate it for a bit longer. The people are, again, differ. You give the same options to everybody, and most people will pick one or the other. The important thing is that is an informed decision. So you've got to tell them what the options are, what potential risks of each are, the benefits and the potential risks and the pros and cons. Every procedure has that. Yeah. So for instance, if we do the posterior, the neck, the operation from the back of the neck, that carries a potential recurrence risk. It's still low, probably about 5% or so. And some people don't want to take that risk, and they want to go to have an operation through the front of the neck, which carries a really good success rate, and there's no chance of recurrence because you remove the entire disc. And again, some are really risk averse, and if you don't want to have surgery no matter what, injection is a possibility for you. The other thing to mention that I've forgotten to allude to are medication. There are specific medications we can actually prescribe, and these work on the nerves that are causing pain, but all the rest of the nerves as well, so potentially can carry risks of concentration problems, swallowing, sleeping problems, etc.
And you can see me sort of nodding about the medication side, which perhaps as a physio might be a bit strange, but actually from a physio perspective, sometimes in order for us to really progress with the strengthening the muscles, getting the movement back, the medications can make the world of difference. And coming to see someone like yourself who, most of the time, I'm sure you don't choose to go down the surgical route with most of your patients, and yet the right medications and going to see a specialist that understands what medications work for that, or are most likely to work for that particular individual, is super important. And then that just makes my job a lot easier. So yeah, working together is the way forward. So that's brilliant.
The value of reassurance and seeing the right specialist at the right time is absolutely crucial. And if a patient comes to me and say, look, within 2 weeks of onset of pain, and if I tell them, look, at 6 weeks, you might actually be a lot better, I'll give you medication in that time and see what happens. So you take it in stepwise fashion. Surgery is absolutely the last resort.
And I think on that reassurance note as well, I think if there'll be some people watching this who will probably have quite severe pain, and both of us know full well that just because somebody has extremely, that sometimes it can be extremely debilitating pain that's really affecting their day-to-day function, it is still possible for them to get better, and severity of pain is not an indicator that they're not going to improve. And it's sometimes very difficult for patients to understand that when they're in the midst of that really nasty, particularly if it's nasty nervy pain, to imagine ever being able to recover from it. But I think that just to have that reassurance that the chances are they will recover with the right approach, I think that's, as you say, just super important for people to understand. Yeah. Okay, well, I think we might wrap up on that note. Actually, it's probably quite a nice positive note to wrap up on. Is there anything else that you would like to add before we say goodbye?
Just to say to viewers, if you have symptoms that are progressing and getting worse, just seek advice, listen to the body and make sure you get checked. Even if it's to say, fine, carry on.
Yeah, absolutely, absolutely. And if you would like to get in touch with Mr. Ibrahim, then please do email him. I will put the email address at the bottom of this video, but it's ibrahim.admin@lips.org.uk. And to get in touch with me, as always, it's Lucy@Octopus Clinic. I'd just like to finally say thank you so much for joining us, Mr. Ibrahim. You have been an absolute superstar, sharing your knowledge and your time with us. So thank you very, very much indeed. I'm sure everyone watching is super grateful.
Thank you for having me.
It's a pleasure. And for those of you watching, please do let me know what you would like me to do a video on next. Until the next time. Bye.